Chapman, and he'll introduce our panels. Take it away, Rick.
Thank you, Elisa, and thank you for everyone who's stuck with us this far through the day. And today we'd like to take this next panel to move the discussion a little bit forward and ask, if now that we've talked about the data and some of the needs there and what decision makers are looking for in that, do we really have the methods that align with what was important to patients and the purposes for decision making? And we've assembled a panel of experts to discuss that. I think really what we'd like to do is talk about, we heard earlier about fit for purpose and what's fit for purpose for decision makers. And so I'd really like to think about that going forward, is do we have everything that we need to be fit for purpose in these decisions? And by this, I want to cast kind of a wide net and really think about not just what are the data that we're collecting, is that fit for purpose, but also do we have what we need to be able to measure and interpret that data once we have collected it? And even broader, do we have the processes and methods in place to pull that measured and interpreted data into decision making and have it be used meaningfully in decision making and in health technology or value assessments? So we'd like to talk about what are some of the insights we're learning about that, what are some of the challenges that remain, what are the things that we're not talking about that may be important to patients but are not really being collected and used. So one of the things we can talk about is, which methods are most relevant to key areas here? How do we match the methods to the purpose of the decision making and of the patient populations that we're looking at? So some of the things we can ask, are we measuring the impacts that matter most to patients? And if we do know what matters most to patients, are we capturing that data at the right time and from the right populations and subpopulations? Are we really getting a representative look at what's going on with patients? And what are the implications of that for clinical trial designs or other data collection efforts that we have out there? Do we need to change how we're doing that to make sure that we're getting data that's fit for purpose? And then finally, as I mentioned, how do we make sure that once we have that information that we're incorporating it into value assessments and decision making in the real world? And one of the things I'd like to touch on is something that was raised earlier, is how do we make sure that if we're getting qualitative data, that it gets the same weight and attention as quantitative data? Can we interpret that? Can we convert that into quantitative data? And if not, how do we make sure that it gets doesn't get short shrift? So to talk about these issues and other questions you may have, we've assembled a panel today, and I'll quickly introduce them and then ask them to give some brief introductory remarks. First, we have Kara Nikolajski, who's the Director of Research, Design, and Implementation at the UPMC Center for High Value Healthcare. We also have Sheena Trena, who's the Global Market Access Leader at Johnson & Johnson. Juan Marcos Gonzalez is the Associate Professor at the Duke University School of Medicine in the Department of Population Health Sciences. And then finally, we have Upal Basu Roy, who is the Executive Director of Research at the Longevity Foundation. And so I'll ask you each to give a few brief remarks as we start, just your thoughts in this area, and we'll go in the same order that I introduced you. So we'll start with Kara.
Hi, everybody. Thank you so much for having me. Again, my name is Kara. I'm the Director of Research, Design, and Implementation at the UPMC Center for High Value Healthcare, which is part of UPMC Insurance Services Division and UPMC Health System. We're a large integrated delivery and financing system in Western Pennsylvania. So just of note, I'm coming at the conversation more from the approach as a researcher. Our small center within the health plan, we actually conduct a lot of patient-centered outcomes research to sort of explore the impact of our clinical programs that we have as part of our health system and our health plan. So I just wanted everybody to know that and keep that in mind, that's sort of where I'll be coming from today.
Thanks, Kara. Now, Sheena.
Great. So I'm Shayna Traina. I am the developer of various patient-reported outcomes instruments for the purposes of highlighting that patient experience in value assessments in my role as a global market access lead. And I've been working in the patient-reported outcomes and market access space for many years now. So that's kind of the perspective I'll be taking.
Thanks. And then Juan Marcos.
Thank you. Thank you for inviting me today. As it was mentioned, I'm an associate professor at the Duke University School of Medicine. And I have been doing preference research for more than 12 years now. I'm also a special government employee with the FDA, supporting the agency's activities in preference-related tasks. That includes the evaluation of submitted data, preference-related data, and the generation of internal resources related to patient preferences. I was also one of the researchers who co-led the first preference study sponsored by the FDA. And so I guess that's sort of my vantage point today. I bring to the table sort of that history of patient preference use and generation within the regulatory space in FDA.
Thanks. And finally, Upal.
Thank you so much for having me. So my name is Upal Vasuroy, and I am the Executive Director at Longevity Foundation, and we are a lung cancer patient advocacy group. Before my tenure at Longevity Foundation, I was a basic scientist in the public health research and academia, and the intersection of methodology and patient centricity is very near and dear to my heart. At the foundation, we'll be doing a lot of patient experience research and with also a focus on patient preferences. And I'm particularly very excited about today's discussion on what methods are fit for purpose. And as a patient advocate, I would challenge all of us to basically answer a very fundamental question: is fit for purpose really fit for patients? And I think in theory, we would all love to see research that replicates the PCORI model, which is truly bottom up, where patients are involved right from the inception of research to the dissemination of results of the research project. But in reality, I think we're always making compromises, giving time constraints, human resource constraints, and financial constraints. And these are all real constraints, and I'm not underestimating the impact of these constraints. But I still think we do need to answer this very, very fundamental question: is fit for purpose really fit for patients? And are we tilting the balance towards rigor at the cost of patient centricity? And again, looking forward to a great discussion today.
Thanks, Upal. Raised a lot of issues that I know we'll touch on as we continue this discussion. So I'd like to touch on one of the things you raised, which is fit for purpose, fit for patients. And you pointed out rightly that there are a lot of constraints that we're going to face throughout this process. So given that, at a health system level, what key criteria should we be considering when we think about issues like that? What should we be thinking about when we're evaluating different methods or measures for looking at patient perspectives?
I'm happy to start us off. Sure. A couple of things that immediately come to mind are: is it usable? And is it not overly burdensome? So if we're collecting information from patients, are we burdening them to provide us every detail of their lives and, answer a million questions so we can better support them? What's that balance of getting the information that we need to move forward versus burdening them? And then also, is it usable? So once we obtain that information, which I'm sure everybody here is very interested in doing, what do we do with it? Do providers have ready access to it? And can the information obtained from the patient and their perspectives somehow be integrated into a provider workflow or a clinical program or a value-based payment design to ensure that it's usable and that it actually sort of benefits the intended audience or the intended target? So I think those are two key things for me, at least from my perspective.
Any others?
I would just add, sorry, go ahead, Dr. Traina, go ahead.
Sure. And from my perspective, and I just have to say the disclaimer that my views are my own and not necessarily reflective of Johnson & Johnson. And thanks to the organizers for inviting me. The US healthcare system really does have a lot of strengths. But as we learned from the patient representatives we heard from this morning, really there's a need for improvement to incorporate patient perspectives and patient voice into everything that we do. But I think I just want to back it up for 1 second. We haven't heard this yet today, and I want to make sure we all understand what is a patient-reported outcome. I think it's really important. A patient-reported outcome is a report coming directly from a patient about how they're feeling and functioning without interpretation by anybody else. And that's pretty much the official definition of a patient-reported outcome. So we were talking about continuous glucose monitoring and time in range, which we learned at the summit at the FDA about 5 years ago. That was about outcomes beyond HbA1c, is very important to patients. But we heard from patients this morning, different goals for different people. There's a lot of heterogeneity. There's no specific amount of time in range that we could say is of value or of less value, because it really depends on the patient's perspective. So a patient-reported outcome regarding time in range would be something about how they feel, about how they're doing with respect to time in range. So CGM data, continuous glucose monitoring data, can be used to look at time in range for glucose values in a diabetes population. However, it is not counted as patient centricity and including directly the patient voice into what we're doing and when we're looking at value assessments for new technologies.
Yeah, I think that's a good point. And I'll also point out that patient-reported outcomes are not necessarily patient-reported outcomes. And there may be outcomes that are important to patients that are not collected through a patient report, but through other means. And so I think it's an important distinction to keep in mind. Any other thoughts on this before we move on?
I was just going to sort of add to what Dr. Nikolowski mentioned. And before doing that, a big shout out to Dr. John Bridges. I see he mentioned, he put a comment in the chat, and we had the privilege of working with Dr. Bridges on our first patient preference study. And I still remember his first question, which was, are we asking the right question that's important to patients? And Dr. Perfetto mentions the same thing as well. And which brings me to the two other factors that we should be considering when we're thinking of methods. That's accountability to the patient population and transparency. Why are we collecting that data? What that data is going to be used for?
Great.
So, so I would add two additional things. Those are all actually three additional things. But the first two would be generalizability. I think we all have mentioned one way or another, or heard in one way or another, that there's a lot of heterogeneity among patients. And so we need to think about whether the method allows us to capture that. So in my view, generalizability is not quite the same as representativeness. I don't care about the average patient. I want to know about the different views that exist in the population. And that means not matching necessarily the characteristics of the patient in our sample, but trying to get as many perspectives as possible so that we can understand the distribution of those views and make an assessment on their prevalence, right, within the patient population. The other thing that is really required of any sort of data is validity. I mean, we want to make sure that the information that we're getting is indeed representative of the patient perspectives. We live in a system in the health industry where there are a lot of stakeholders, interactions when it comes to decision making. And to the extent that we're using decisions to infer what patients care about, we need to be very careful that we're not misinterpreting those signals, and that we're able to really capture what the patients care about. And so I think that that's going to be critical moving forward, being able to get some assurance that the perspectives that we're getting are truly representative of the patient perspectives. And then I wouldn't be a very good economist if I didn't bring the concept of cost. In an ideal world, we would be able to collect all the information that is necessary to make a fully informed decision, but oftentimes we cannot afford that for various reasons. As Upal mentioned, there are some constraints, and so I think that just highlights the need to prioritize within our work. And I think that's yet another way to think about how patient preferences come into play and patient perspectives come into play, because if we are to prioritize, I think we definitely need to consider the patient perspective on what ought to be prioritized. So it's not just universally what we're going to be measuring, but if we can't measure it all, what would be most critical?
Yeah, those are all good points. And I think we could spend a lot of time talking about a lot of these issues. I did want to come back to one thing though, which is it was brought up that this data needs to be usable. And I would like to say beyond that, it needs to be used. And so one of the things I'd like to ask is, assuming that we figured out how to collect reliable, valid, generalizable data from patients and what's important to patients, how do we then make sure that that gets used by decision makers and gets used in health technology assessment or value assessments going forward? Are there certain processes or procedures that we need to have in place to help out with that?
Yeah, absolutely. I think I can start, and then maybe Juan Marcos, it looks like you have something to add as well. I'm thinking that, we want our data that we collect from the patient's perspective to be reliable and valid. And one way to do that is to stop putting in our peer-reviewed journal articles that a limitation of the study was that these are subjective data or these are only patient-reported data. That's actually valuable data, and it's not a limitation of the study. And that's something we can all do today. The next publication that you're writing, partner with patients to write the publication and have them as co-authors, have them help interpret the data that you're looking at. And secondly, make sure that you're not putting that patient-reported outcomes data is a limitation of your research.
Good point.
Yeah, I think that's absolutely right. We face sort of a challenge when it comes to selling how rigorous our methods are. Preference research is not going out there and putting together an opinion poll. It's actually research. It's an experiment that we're conducting, trying to be very rigorous about what matters and what doesn't matter as much, right? And the same with PROs and COAs more broadly. I think it's a scientific endeavor, and so I feel like we need to work a little bit to help others in decision-making roles understand that and sort of give it the value that it has. From my experience with FDA and just broadly how FDA has tackled the incorporation of patient preferences, I guess what I wanted to add is that in that context, it really helped that FDA identified a very specific use for these data. There were a lot of ideas out there in terms of how this could be used for regulatory decision making, but they focused on one specific aspect, benefit risk evaluations, and how they could supplement the information that they were getting from the trials with patient perspectives on that matter. They took, I have to give them credit, particularly the Center for Devices, they took the leadership role and actually sponsored a study and got their hands dirty and did the study with the research team. And it was at that juncture that I believe they realized that this is actual research, that there are also a lot of decisions that need to be made when you're conducting this research, and that it's not as easy as it seems. And so for that reason, I think they started to understand that the value of those data, and that it's not as easy as telling someone go out there and collect some data. It has a cost, it takes time, but it can be incredibly useful. And so once they adopted and issued guidance on that matter of benefit risk evaluations, the doors were open. And since then, all these other ideas about how we could use this evidence from patient preferences have reached other areas that we'd never thought could be actually impacted by this information. I mean, we're talking right now, there's some discussion about potentially using preference information to determine how to power a trial, because the value of or the weight of the evidence is not equally appreciated or valued, I guess, by the patients. If you're talking about a very critical outcome, you may want a lot of evidence on that, maybe beyond the 95% confidence level, right? But if you're talking about something less critical, then something, a lower level of confidence might be completely acceptable. And so that can actually trigger a real change in terms of trial design. And that wouldn't have been possible if the FDA wasn't convinced first that these are valuable data and understood how to use it as a proof of concept through that benefit risk evaluation approach.
Great. Thanks. That's a good example.
Just to build upon what Dr. Trina was mentioning about the inclusion of patients in the actual dissemination process, just taking that a step further, one thing, and again, we focus a lot on PCORI funded research, so I know they're kind of different in the way that they approach it, as Dr. Roy had mentioned before, and they are very patient-centered, but we try to involve not only patients, but any stakeholder that's relevant to the study, which usually it's providers, community members, what have you, in the development process throughout the entire research sort of continuums, from developing the questions, determining outcomes, and it can take a lot of time, but it is worth it in the end when you want to actually take the information and translate it and scale it for use across a broader, arena without kind of doing that legwork. We find that you're less likely to be successful because you don't have the buy-in, you don't have the preferences noted of all the various stakeholders that may be helping support the scaling of a program or an initiative. And another quick thing to mention is that one thing we also like to do is make sure we're sort of taking an implementation science framework approach to what we're doing. So kind of looking at the various contextual factors that come into play when implementing something. So we're taking as many of those as possible into account within reason, but that definitely helps us with sort of finding ways to better utilize the information we're getting and then scaling a program or an initiative or what have you. So.
Thanks. And this is a good time to put in a question that came from the audience. Can you give an example of how UPMC has used patient data to inform clinical workflows and how that was usable?
Yeah, I have quite a few examples, but this is more kind of a boots on the ground example. We are in the process of completing a large PCORI study looking at care management services, both virtual or digital versus in person. And, when implementation first started, I think a lot with research and with, any sort of clinical program, there are certain people that believe they're the experts because they're the ones that made the program or are implementing it, but we don't do our due diligence to talk with the people that are utilizing the program kind of upfront. And we've obviously learned from these lessons, but when implementing a new technology, for example, for remote monitoring, which is becoming very popular, we were finding that a lot of people were just having a lot of trouble engaging in the remote monitoring program. And we wanted to figure out why. So, through interviews, we do qualitative interviews, through just kind of having phone calls with individuals that were using the technology, we were finding common themes about, what were some of the challenges and what needed to potentially be changed in our workflows to better support people that were using our program. So that direct patient feedback was then integrated into our clinical workflows so we can promote engagement in the technology that we were hoping people would use. And it's definitely worked out a lot. We saw a really big increase in engagement in the program.
Thanks. That's a good example. So we also heard earlier a little bit, I think it was from Juan Marcos, about the need to ensure generalizability and validity of patient-reported or patient-important data. And so I just wanted to open up the question about what level of rigor or minimum standards do we need for this data? And is it different than what we need for other types of data? And does it differ by decision maker or purposes that the data is going to be put to? Juan Marcos, I think you brought up the validity issue. I don't know if you've got thoughts on that.
Yeah, I think that really depends on the use of the information. If you're talking about early development of a product where a pharmaceutical company, for example, is looking for patient input, they might need something that is perhaps perceived as less rigorous in some ways, but provides the information that they need in a cost-effective way. And I would argue that that is definitely a better outcome than saying, no, I cannot do this unless it costs $500,000 and it's done with 20 sites across the country, right? And so on the other hand, I think there is an expectation, particularly when we come to the point of mixing clinical data with patient-generated data, that the standards ought to be similar. Whatever standards we follow for the clinical data ought to be similar in this patient-reported information, being patient-reported outcomes or patient preferences. And so with that in mind, I do think that there, I guess all the features of what you would expect with conducting good research would apply to this kind of work. There are guidance out there. Importantly, FDA has issued guidance on the use of patient preference data and on the use of patient-reported outcomes. But outside of FDA, there are professional organizations that have put really good practice documents like ISPOR or MDIC that I would say serve as great reference for anyone who wants to conduct this kind of research. Ultimately, I think the issue is definitely dependent on the user and the ultimate user, and including the generalizability. I want to make sure that I'm clear that I didn't mean to say that, again, we cannot have research that doesn't consider every person in the community, but we do want to give as many people as possible the opportunity to share their views. I think there's a lot of value in having a small cohort of people providing very insightful and in-depth information about their perspectives too. So I think that's also something to consider.
Yeah, and I also think that it depends on the disease state that you're asking questions of. I see Upal nodding his head. Some diseases are quite rare, and so there may be very few patients that you can contact and ask about their lived experience. And some disease areas are chronic diseases that are very, very common, like type 2 diabetes or cardiovascular disease. And then there's symptomatic diseases and asymptomatic diseases. And so the research questions there and the way that you get at the patient lived experience can vary widely depending on which disease state you're studying.
Thanks. And I wanted to ask, this may be a question for Upal. We've heard about the distribution of perspectives and the need to get a wide or broad perspective on patients' preferences. Health technology assessment and value assessment, and to a large extent, a lot of clinical measures really concentrate often on measures of central tendency. So what's the average patient like? So how should we think about that and bringing in those sort of broad distribution of perspectives? How do we have that factor meaningfully into decisions when a lot of the machinery seems to be built around looking at the average patient or typical patient?
Thanks for that question, Rick. And if you'd asked me that question 10 years ago, I would have said, let's go with central tendency because there is an average patient. But as a patient advocate, I would refute that and say that there is really no average patient. I think we are limited by our methods to really gather the patient perspective in its truest sense, to really gather that wide range of spectrum of opinions and perspectives. So I think we settle for central tendencies given the limitations of our methods. And I wouldn't actually say the limitations of our methods, the limitations of the attributes of rigor that we associate with methods. I think the methods are the methods, but I think we associate different levels of rigor with them. And I'll give you an example of what I mean by there is no average patient. If you take lung cancer as a disease, and again, sorry for wearing my lung cancer hat, if you're just talking about the general lung cancer population, yes, using a quantitative study to sort of get that average patient perspective might be helpful. But as you sort of go into the incredibly more molecularly segmented patient populations, I think that's when I think we sort of start hitting that roadblock of, is there really an average patient that represents sort of the entire perspective of this very rare subset in all its entirety? And that's where I feel that I think going back to what Dr. Trainer said, sort of not limiting ourselves by whether we choose a qualitative methodology or a quantitative methodology, whether it's subjective or objective. I think we should consider all methods to be objective. And that's where I feel that there is an incredible role for qualitative methodology to sort of really understand what that unique patient experience is and triangulate that data with what we have from quantitative studies. And I'm not saying that this triangulation will give us the average patient perspective, but I think it definitely moves the needle a bit more than just depending on quantitative studies that we traditionally, as a community, have depended on.
I would add to this, Upal, I think, and Kara said this, there's a methodology for pulling out common themes from our qualitative and quantitative research to look at what matters to patients or what matters most and what's floating to the top. But also with respect to our methods in data analysis, we saw this morning an example where the baseline patient-reported outcome score predicted the outcome. And we've looked at this in oncology studies as well, where the patient-reported outcome predicts the clinical outcome over time, in order over time. Also, I've worked with data sets where a third of the patients improved, a third of the patients stayed the same, and a third of the patients declined over time, all on the same PRO instrument or measure. What we did then was we had to analyze the data separately. Of those who had a decrement at baseline, what happened to that subgroup? Of those who literally stayed the same, what were their clinical outcomes, et cetera. And that really helped. And it was actually a valuable use of the data. And it was slightly a different way than what we're used to doing. And I did feel that I had to fight a little bit with the biostatisticians who are not used to those types of methods, but it was appropriate based on the data leading the way. The patients told us how they were feeling and functioning. We believed them, and we utilized the data to the best of our ability.
Thank you, Dr. Trainer, for fighting with the biostats
folks. That's right.
Not that I have anything against them, but.
I've had those fights from different perspectives, I think. So one of the things that just came up was and this is something we heard earlier from one of the panelists, is the need for measures that cut across diseases and to be able to look at common measures across diseases. And that, I think you mentioned rare diseases, Upal. It's something that's going to be very important when we start looking at biomarkers and ultra rare diseases. And it sounded like, Sheena, from your response, that you feel like we have at least some of what we need to be able to start to pull apart some of those measures that might be common or cut across some of these disease states. Did I interpret that right?
Well, best scientific practices tell us to use both a disease-specific measure and a general measure of health-related quality of life. And so we have some general measures. And I think I heard in the last session or two, some of these legacy measures might need a second look, an update, or maybe retirement. But those general measures of health-related quality of life are one way to look across disease states. But I think it's critical to have the disease-specific measures because of the very unique nature of each particular experience. And then we have places in chronic conditions, especially where you have multiple comorbidities and competing risks. And so you may need to measure sort of multiple different disease states simultaneously within one population or within one person.
Yeah, from a preference standpoint, I think this is an area where the methods need to evolve and need to help us get to that comparability or standardizing information across disease areas. And part of it is because we define preferences as people's willingness to accept trade-offs, right? Things are as valuable as what they're willing to forego to obtain it. And so a lot of times the vehicles that we use to obtain that trade-off information is to ask them to evaluate what would happen in their own disease and what could change with their disease if they take different treatments. And so as you probably all know, context matters. And so building a context that involves multiple disease areas into a single instrument is a challenge, is really a challenge. And so I think this is an area of ongoing research. I know that there's a lot of interest. There's some researchers out there doing some interesting work, but it's a part that we need to develop further to be able to get to that balance that Dr. Trina was mentioning, get the individual level information and put it in the context of this broad view of everything else that could be happening to this patient or others.
Can I just really briefly, I want to mention, and I have limited knowledge on this, so forgive me if I'm not getting something right for those that may know more, but promise measures, they're patient-reported outcomes measures that are underway, being developed, have been developed on many, many disease states, but I think they have the capability of, for example, in the case of depression, if you are a psychiatrist or psychologist, you may want to do a more rigorous evaluation of a person's sort of depressive state. Whereas if you're a primary care provider, you might want to just take out a few of those questions to do sort of a basic assessment. And I believe that the promise measures allow you to sort of do that. So you're still using similar questions. You may be using more, it may be more, there may be more specificity depending on who is administering them. But across sort of a healthcare organization, you may be able to get like kind of a fuller picture in using those. So just throwing that out there.
Yeah, that's a good point. And it was something I had thought of earlier when something had come up about ways to maybe focus in on certain disease-specific measures, but also have that fit within an overall generic quality of life measure. There are frameworks out there that are trying to work to flesh that out. I wanted to turn now, we had a question from the audience about how to involve patients in this process, not just as research subjects, but as actually, part of the process. And I think someone mentioned earlier the need for accountability and transparency when we're working with patients. And so how do we ensure that we are being transparent and involving patients from the beginning and throughout the process? And what are some of the things we can do to increase the transparency, the accountability? We heard also, some of this work puts constraints on the patient advocacy organizations because of the amount of resources that are involved, not just dollars, but also time and effort. So what are some best practices we should be considering there when we're trying to involve patients in this process?
Start early, start with the end in mind, include patients from the very beginning. So in the pharmaceutical research that I do, we include patients in protocol design, the selection of endpoints, the design of the study, as well as the site selection. We learned from certain patient groups that the site mattered, whether or not there was internet availability while the patient was at the site was very important to a particular group. That helped with our site selection. It helps us run the trials more quickly and get better quality data when patients are involved from the beginning. Then obviously working up the analysis plans, the final analysis of the data that had been collected, reaching back to the patients that participated in the trial that supplied their data and telling them what the findings are is always really valuable. Writing lay summaries can be very helpful. And then all the way through and pulling through those publications that I talked about kind of at the end of the line, as well as into sort of real world studies or phase 4 studies, we call them, which is sort of after your product launches into the market. You want to continue to involve and evaluate that patient perspective in sort of that real world setting. There's a great article that just came out by Kathy McLean and colleagues at the New York Hospital for General Surgery. It talks about using patient-reported outcomes, or PROMs, measures in clinical practice. And one of the key points they make in that article is to explain to the patients why you're collecting that information. I think we heard that earlier today. Just partnering with people and not just using them as lab rats or research subjects, but really being in partnership in every sense of the word with those communities that you're serving, I think is the way to go.
I totally agree with Dr. Trina on everything that she just mentioned. I think that's gold standard, and that's what we strive for, to involve in sort of every element of the process. A couple of methods or best practices that we've used, and I think these are they vary in terms of, how long you're engaging a stakeholder and how many times you have the opportunity to meet with a patient group. But we've used things like stakeholder advisory boards or steering committees. So we convene a group of the target population or their caregivers a few times a year just to talk through general implementation strategies or, a research design, whatever the topic area is. But it does give us a way to get some sort of quick feedback, and we keep them in the loop by giving updates over time. We've included patients as study investigators on some of our larger trials, which has been just absolutely worth it in every way, especially just having their viewpoint at all points has been super beneficial. We use things like Delphi technique. If we need to prioritize outcomes, that's a good way to engage multiple stakeholder groups, including patients, to understand what outcomes are important to them. Learning collaboratives are another way. Focus groups and interviews. These are all things that we do for all of our studies, again, with varying levels of intensity. But in terms of best practices, I think those are some examples at least to consider.
Thanks. Upal?
I think Dr. Traina and Dr. Nikoliski both of them made fantastic points. The only thing I would sort of add is to keep a certain amount of flexibility in our methodology. I think when we are doing hypothesis generating or exploratory research, I think we can be flexible with methods. And I think those types of studies typically are more attuned to really gathering patient input. But when we are doing studies which have a clear fit for purpose kind of definition, I think we've already sort of decided the methodology if we have a fit for purpose, right? And I think that's where we need to be really flexible and adaptive to patient input and be able to tweak our methodology in a way that we don't lose sight of the fit for the purpose, obviously, but at the same time, make the methods meaningful to patients. I would really encourage adaptability and flexibility in study designs when we are thinking of fit for purpose.
Thanks, that's a great point. So I know we've only got a couple of minutes left, so I thought I'd finish by letting you each have a chance to give final thoughts. And I thought I would sort of frame this with a question we got. It's kind of a call for IVF and other organizations to pull together a set of next generation measures in this area, and really to organize a platform to get consensus on what to use as part of a next generation measure framework to really move us beyond the current measure frameworks we have. I wonder if you had any thoughts in terms of just if you could pick one actionable item to help us move towards a next generation measure framework. What would you push for? What would be your pet option here?
Well, I'll start with a bit of a pipe dream of mine. And of course it has to do with preferences, but I've always felt that this idea that in every other branch of science, you have to have 3, 4, 5, 10 studies to claim that you are anywhere around the truth. And with preference studies, we conduct one study and we have to accept that that's the truth. It's a little misleading and naive. And so an ideal scenario for me would be to be able to use the information from the preference studies that we do and not just prepare a report and let it die on the shelf. I think, and this is actually a place where I think the patients would have a critical role to leverage the results from work like this and build tools that can be returned to the community to be used in clinical decision making and used to collect information prospectively. Because another thing that happens with preferences is that they can evolve, right, based on experiences and context. And so I feel like having the ability to understand the perspective of patients, not at a particular point in time, but in a continuous manner, could lead to very beneficial information and better outcomes.
Great, thanks. Sheena?
So sure, I can go next. I think that when I'm thinking about the future of measurement of the patient perspective and how to best include that into value assessments, I'd like to be able to include the value of hope. and other concepts that aren't currently captured well or utilized well in value assessments. I'd like the value assessments to be patient-centered, but I am feeling that the incentives are off. So we heard this morning from Dr. Dana Gelb-Safran that the quality metrics are really they're not outcomes based, they're just processes. So did you measure the patient's BMI? But if their BMI was 50, did you do anything about it? Did you help the person lose some weight and become a healthier version of themselves? That's not captured today. So what we're paying for, what payers are paying for, what our healthcare systems in the US are paying for, the incentives are misaligned. So I'd like to see us come more to alignment so that it all becomes more patient-centered.
Great, thanks. Kara, could I ask you for your final thoughts?
Sure, yeah. I agree with all that's been said. I think one thing I would love to see in the future state is better data sharing capacity. I'm thinking just from the perspective, one example would be from sort of addressing disparities, social determinants of health. We're all very much interested in the patient experience related to that. And we are trying our best, at least at our system, to link data sources from places like community organizations that are serving a lot of our members for things like housing insecurity, food insecurity, things like that. But it's so hard to take the claims data, the patient reported data, the EMR data, the community organization data, and kind of have it all in a workable space so we can take all that information and sort of move forward with the best plan of action.
Great, thanks. Then Upal, you get the last word.
I don't think I have much to add to what folks have already said, but I just echo what Dr. Gonzalez mentioned about if I were to sort of envision the ideal situation for research, I would definitely think of research and methodology that does provide value to the direct participants, to the community in real time. And I use the example of PRO measures when we've interviewed patients with lung cancer and are participating on clinical trials about why they fill out PRO measures. Most patients were unaware of why they were filling out PRO measures, and they thought that PRO measures were being asked to treat them or to manage their symptoms real time. So there was obviously a huge disconnect between what patients were doing and what was asked from the actual study. And that's where I feel that, going back to what Gonzalez mentioned, that if we have a mechanism where the research that's being conducted, the data that's being collected can inform patient decision-making in a real-time fashion or policy-making in a real-time fashion, I think that's truly impactful, because I think that really gives patients the opportunity to see their voice really translate into action, and that's rarely the case.
Great, thanks. And I want to thank all of you for this great discussion. I think we could have gone on much longer, but I feel good that there's a lot of work to do here, but it's doable. There's things we can bite off and make a difference on. So thank you very much. And now I'll turn things back over to Lisa.
Thank you, Rick, and thank you to our panelists. I agree with you, Rick. We probably could have spent another hour, and I wanted to honor and acknowledge we've received great comments in the chat and wonderful questions. We've done our best to get to most of the questions. A few, including some directed at Dana Safran this morning, we didn't get a chance to answer live. I wanted to let everyone know we will be seeking to answer all of the questions that have been submitted. We'll do so in writing, and we'll post the questions with the answers on the IVI Summit microsite in the next couple of days. So stay tuned for that. We're going to pivot now to some closing reflections and reactor comments. If I could please invite back to the screen Annie Kennedy, who you met earlier today with our opening patient panel, and Margaret Raham, who is the Vice President at the National Alliance of Healthcare Purchaser Coalitions. And I'm pleased to be with them and have their insights and reflections in a moment. I do want to also draw everyone's attention to, in the chat, there was a link for a SurveyMonkey in order to receive your feedback and your thoughts on today's summit. It's really important for us to hear feedback from all of you. So Annie and Margaret, thank you for being with us as we close out this incredibly rich and robust discussion. we really spent our day starting with patients, and we've been on this journey. And I think the importance of the patient experience, patient priorities and preferences has come through loud and clear. I think we have a consensus on that, which came through in our summit last year. I think really what I would love to hear from both of you is really, where do we go from here? What are the action items? So we have this consensus, right? And now we have to do something about it. So Margaret, I'm going to ask you first to give us your thoughts on steps we can take and maybe a bit of a call to action. And then to you, Annie, and then I'll invite Jen Bright from IVI to close us out, and we will end on time at 2 Eastern. So Margaret, please.
Okay. Thank you. And thanks for inviting me to participate in this. You know, to have one call to action is a little hard, but what I do want to highlight is the fact that we are having this conversation. The fact that we're bringing all of these folks together at this point in time, it's timely. We have this silver lining of an opportunity that's come forward because of what's happened in the pandemic that's shaken us all out of our status quo thinking to really begin to take a look at how do we address improving patient-centered outcomes in a very thoughtful way. And I think we've started to dive into that here, and that we've been able to, you know, there were a lot of very wonderful points. I actually have 4 pages worth of notes that as I was going through the day, but if we're looking at a call to action, is one of them is that we continue to come around the table. Healthcare is evolving at a very rapid pace. We can't continue to do our work, whether we're a researcher or we're on the payer side or even on the employer side, which is the perspective that I represent, to be able to support patients in the way that was done even 18 months ago. So we have to begin to take a look at how to evolve our thinking and get out of our boxes in a good way. I mean, there's good learnings there, but there's also an importance for us to evolve our thinking so that we are moving forward and measuring the right things that matter. I mean, I heard that as a consistent theme throughout the day, is in measuring what matters, but matters to who? Is it just to the patients? You know, we need to make sure that we're looking at, you know, from an employer's perspective, and then I'll wrap up my comment here so Annie can join in. But from the employer perspective, they actually look at patients across the board. They're looking at a population health perspective. They're looking at total cost of care. They're looking at health equity issues. They're looking at how to be able to manage low care work, you know, low wage workers. They're managing a lot of things, and how to be able to bring the right measures together so they aren't overly reliant on benefit consultants and payers to give them feedback. So, you know, I'm glad employers are at this table and having this discussion. So I'll stop there for now, but there's a lot here to dive into.
We appreciate you bringing the perspective forward. And I'll just share a little anecdote before, Annie, I ask you to hop in about employers. So we were having a discussion with another panel of folks a couple of weeks ago, and got the question from a patient about, what if my employer's health insurance plan doesn't cover something? What can I do? And a panelist who had been at a payer, a chief medical officer at a payer, said, go talk to your HR benefits person, because depending on your type of plan, if it's self-insured or not, sometimes it's just a matter of you go and raise it up to your HR person, and they would call me as the chief medical officer, and we would fix it with 2 phone calls. And you could have seen, you know, people's jaws drop. They were like, can it really be so easy? Not always, but I think your point is important, that we all need to have our voices heard. Everybody at the table is important, and we need to be all together, collaborating and getting outside of our silos and our boxes and really coming together. So thank you for that. Annie, please, some reflections, and if you have a call to action or actions that you want to put forward.
Yeah, thank you. And I really appreciate those comments, Margaret. I think from my perspective, I think it's similar to Margaret's maybe, and that value to whom, I think, is a part of the question. And I think we all want to be able to trust the outcome of the value assessment. I think what we've heard today is a lot of really phenomenal work being done by a lot of different partners to ensure that there are metrics and really robust science behind how patient experience data is being collected. And we've heard that throughout the day from a lot of different panels. I think that one of the things that struck me throughout the day was how is this data being incorporated into the existing methodologies that are being utilized right now in the value assessment space. And one of the questions that one of the case studies that we talked about today was the sickle cell community's experience within the ICER assessment. And ICER is certainly not the only value assessor out there, but I think the question we should be asking of the sickle cell community and others, and I was somebody who helped lead a value assessment process for the Duchenne community, and we did a lot of work engaging with ICER, is at the end of the day, did you feel the juice was worth the squeeze? Did you trust what the outcome of that assessment was after you put so much work into the engagement? And the answer a community would come back with would not be based on whether or not the entire community had access. That we understand that it is not an all or nothing. But what we want to be able to do is trust that those decisions were informed by our data being a part of the central methodologies, that we are not contextual considerations, but we're a part of the base case of those methodologies. So my call to action would be that as HAVE and National Health Council and IVI and others are doing some very meaningful work to ensure that all of this data we're collecting is being pulled forward, that we are also simultaneously looking at where it's being integrated into the value assessment space and into those methodologies. And I think we need to collectively be stepping back and seeing whether or not there's an opportunity to update those methodologies as well.
I think those are great points, Annie. I think the threshold question is the juice worth the squeeze is a really important one. And where and how are the data being utilized? It's not just a sidecar, right? Is it a key ingredient? And then are we using the right methodologies? And are we then looking at what the results of the outcomes are? So that is my cue. My alarm just went off saying that we are just about at time. So I want to thank you both for your reflections and for bringing your perspectives forward, and particularly Margaret, thank you for bringing the employer perspective forward, and Annie, of course, the patient view. I want to thank all of our panelists again. I'm going to invite Jen Bright, the Executive Director of IVI, forward for some closing reflections. And I just want to remind everybody that, that there is the opportunity for the SurveyMonkey for your feedback. Please visit the microsite in the next few days for additional content and answers to the questions. And Jen, I will turn it over to you and let you close us out. I hope everyone stays well. Thank you so much for being with us.
Thanks, Elisa. Thanks, Annie and Margaret, and all of our panelists today. Thanks to the audience who's been so attentive and vigorously engaged. When we started this process with an idea that we put forward to PCORI, we knew we were tackling an ambitious topic. And as you've heard today, there's lots of threads to this particular area. But I think in balance, we definitely exceeded our goal to bring forward some of the top line thinking, to challenge ourselves, to identify where are there opportunities to move forward. And as you heard from our reactors, what next? What's the next step? So a couple things that resonated with me, and I'll reflect a little bit on how IVI wants to use this entire enterprise in our work. First, I think the overarching theme today that I heard was that we, as a community, no matter what hat we wear or what seat we sit in this conversation about value and patient-centered care, we need to embrace and lean into change. So we heard change in a couple of contexts in regards to quality measurement and how we need to stop talking about it, and we need to make the leap from 1,000 points of process measures to really doing the hard work to say, what are the outcomes that matter to health? Secondly, we heard a lot about the vigorous and robust amount of work being done to do a better job at capturing patient-driven data, whether it's starting with patient communities or other community organizations. There are a whole host of organizations that are working on how do we improve the pipeline of things that are important, of data and pieces of information that are important to patients and are meaningful to their outcomes, both in terms of their clinical care as well as their quality of life. And we heard, I think, some provocative things to think about use of such data, that there's some important work and really, I think, soul searching and kind of blunt conversations that we have to have about what are the alignment of incentives for the use of patient-driven data. We have some good examples of where organizations like FDA and PCORI are really leadership voices in driving the creation of that kind of data, but also identifying very specific uses. And I think we need to continue to push on those successes and collaborate with other organizations that should be doing the same. Just to say that we think that we need to bring more payer PBM and benefits design companies need to be at the table having these conversations. It's in their best interest to help improve the ecology of this data as much as it is incentive for an innovator who's looking to bring a product to a market or to a patient community who is trying to improve quality of life and outcomes for the patient population that they care about. And then lastly, we heard about methods, that there's an enormous amount of evolution happening in thinking about methods, even within the last decade, to speak to some of the things that Upal said about new thinking and new methods. And we need to stop putting strictures on the evolution of those methods. And, to quote Upal, is the fit for purpose actually in the best interest of the patient? Are we hamstringing ourselves by getting hung up on the methodology? And I'm not an economist, but I'm not saying we shouldn't care about method, but there's got to be some dynamism to that conversation. And we have to understand how we create a real learning health system in real time. So those were some of the things that I heard. As regards to how IVI views this discussion, first of all of this input, dialogue, your responses to the survey, which we really hope you'll take just a few minutes to answer as you close out your day, all of that feeds into 2 more days of discussion. We have some invitation-only small group discussions with stakeholders that represent the whole spectrum of actors that were participating today to really dig into what some of the themes are. How can we bring forward some tangible action items? And our intent from coming out of this summit is to prioritize some areas where we can really make some meaningful change and to do so in a way that's collaborative. I think there was a comment or a question posted about, can IVI join with other organizations to really identify next generation measures? The answer is that's our goal. We at IVI, we consider ourselves a learning lab. We are about bringing together different actors and thinking through what's possible. Juan Marcus's comment about pipe dream resonated with me, but I prefer not to use the term pipe dream and instead say it's our brass ring that we're reaching for. And how does IVI bring the themes and the ideas that come through these conversations today and as we go forward to tomorrow and November 4th? And how do we use those as a launch pad for different partnerships and conversations, not only for our own work at IVI and our models and the methods work that Rick does, but also a challenge to other organizations to take action. So with that, I just want to say one more final thank you to all of you. This has been a wonderful set of dialogues. I've learned a lot. I hope you have too. And we do welcome your offline, online survey input. Any way that you want to share your ideas and feedback with us, we will take it and use it for good. So thanks very much for your time today and have a great afternoon.